Eric, are you all set?
I'm all set, Bill.
Okay, thank you. So hello everyone. Welcome to today's OBSSR webinar entitled Behavioral Health and Injury Prevention, the Emergency Department as a Window to Community and Population Health. I'm Bill Riley. I direct the Office of Behavioral and Social Sciences Research at the National Institutes of Health. Before I introduce today's speaker, a few housekeeping items. Today's webinar is being recorded, and the recording will be made available in about 2 weeks on the OBSSR website, so you can check it out then. And also point people who may not have been able to attend in person today to see it on video later. Today's presentation will be followed by a Q&A session. Our own Dara Blackman-Demner at OBSSR, who leads our violence prevention research efforts, will be coordinating and facilitating that Q&A session. The phone lines are muted during the webinar, so you ask your questions and your comments via the Q&A and chat features. So to ask a question, send a comment, you click on the Q&A and select all panelists, and you type in your question and send. And you can do that anytime during the period during the presentation. You don't have to wait till the end. And then Dara will facilitate the Q&A at that point. So I'm really pleased today to introduce our presenter, Dr. Rebecca Cunningham. Dr. Cunningham is the Vice President for Research at the University of Michigan, where she's responsible for fostering the excellence and integrity of research across all 3 campuses there. She has broad experience as a researcher, administrator, educator, and clinician, including more than 20 years spent as an emergency medicine physician at the University of Michigan, as well as at the Hurley Medical Center in Flint, Michigan. Her career has focused on injury prevention, opioid overdose, substance misuse and prevention, firearm injury prevention, and public health. She's the former director of the University of Michigan's Injury Prevention Center and served as Associate Vice President for Research and Health Sciences, and is the former Associate Chair for Research at the University of Michigan's Department of Emergency Medicine. In 2019, Dr. Cunningham was elected to the National Academies of Medicine. The Society for Academic Emergency Medicine and the American College of Emergency Physicians both awarded her the Excellence in Research Awards in 2019 as well. So it's really a great honor and pleasure to welcome Dr. Cunningham that will present today on behavioral health and injury prevention, the emergency department as a window to community and population health. Dr. Cunningham.
Thank you so much, Bill. It's really a pleasure to be here today. So as a bit of an overview for our next 45 minutes, I'm going to spend probably the first 10 or 15 minutes talking a little bit about violence prevention and my research in violence prevention in both the emergency department and the community. And then I want to transition for the second half an hour to really our work on firearm violence and firearm injury prevention as an area that I think people have less exposure to typically and might be of interest as well. It seems that whenever I do a talk, there's always recently been a mass shooting, and this week has been no different. And so I'd like to focus the second the half an hour on that topic. But let me start off first by way of background. As you mentioned, my foundational experience and lens through which I see the world came from my training in emergency medicine. And really as the opportunity to see and take in both all of the behaviors possible from human experience from the vantage point in the emergency department, as well as just the tremendous opportunity to interface with the systems in place and the community that is outside of our window in emergency medicine. And you know, I think in the lens of COVID and 2020, and I was supposed to give this talk, we were just musing before this started, this week last year, and we obviously postponed it when we shut everything down. But COVID has only shown us more so how the front line and how essential work and how emergency departments function to interface with the public health of our community, and that is the lens by which I have really always worked. Next slide, please. So I won't linger on this, but I think it's important as we talk about violence and violence prevention and firearm prevention, this is the lens by which I came into this work, and it's a little gory, but it's also it's really important, I think, as we think about numbers and statistics and prevention concepts and methodology, to think also about the real people that are impacted and how they enter and experience both violence, the before time and aftermath of it. Next slide, please. I won't linger too much on the public health analogy for this group, but it quickly became apparent to me after looking at many folks like the slide before us, before this one, that it was time to work upstream and to be thinking about how we can utilize the emergency department at health settings, which was my initial viewpoint, to stop people from winding up in the ER, because although there are great miracles of medicine to patch people up, we really need to do a better job on prevention. And we are doing a better job at this now than when I started this work 20 plus some years ago, but we have an awful long way to go in thinking about violence prevention as a public health component, and as how our infrastructure as health systems and community really can be engaged. Next slide, please. I always want to say that although I'm looking at this as the aspect predominantly in this portion, this first portion of the talk through healthcare, that we have, violence as a leading cause of death, as we will talk about, impacts our society and our communities tremendously. And there is not one right location. I often will hear people argue on the places that we should be doing this, and should we be doing this work more in the schools or in our communities or in our neighborhoods? And is healthcare really the right place for this when it's really individual care, one at a time? And my answer to this will always be, we need to be doing it in all of these places, and the work needs to be interconnected. Next slide, please. So as I start this journey and walking you through some of the work in violence prevention over the years, I'll start with this piece, published in the early, somewhere mid-2000 time period, which is where we realized, thinking about what happens to people before they wind up in the trauma bay that gets them there, and what we do with people after they're in the trauma bay to make sure that they don't come back again. And in looking sort of systematically at it, and we've come a long way even in this last decade, but in that decade between 2000 and 2010, we're just beginning to think about how to utilize the emergency department in this way. And one of the things that really stuck out at me at that time, that we quantified some, is that 97% of injured patients in an emergency department are treated and released. And most people still don't realize that even a firearm injury, whether you're a youth, an adolescent, or somebody older, overwhelmingly, you are released from the ED that day. You are patched up and you are treated and treated. And with that, we often miss the major opportunity to deal with all of the psychological and mental and emotional components that go with that, as well as don't often engage in how we break either the retaliatory cycle or the mental health consequences that come after that injury that put people at risk for future both violent injury and substance use. People don't realize so much that if you're a youth specifically, for example, you're not going to interface, you're going to get discharged, you're not going to interface with the inpatient trauma unit. And although we've done a lot of work across the country in increasing resources in our level 1 trauma centers for injury prevention, and thinking about the resources they need to have for prevention of their trauma patients, very few people actually get admitted to the trauma centers. They often go home from the ED. This was true then, and it's true now, although there are some emergency departments and health systems that are working on violence prevention efforts across the country. Most, overwhelmingly majority, provide no evaluation of risk for future violent injury, whether it be retaliation that day or future risk down the road before they're released. Next slide, please. To address this initial need that we saw in about 2009, 2010, myself and Dr. Walton, my co-PI on this, developed the SafERteens intervention thanks to an NIAAA R01 at the time. And this was, we took the concepts here of motivational interviewing, and this is an early laptop device at that time was novel to have in a patient's hand during an ED stay, to do screening with them in the ED. To try to address youth that were coming in, and this is in Flint, Michigan, and looking at what we could develop for a program that would help prevent their violence going out. We know that youth 14 to 18, especially in communities, in urban communities in Flint, Michigan, that no matter what I would see a youth for medically in our emergency department, the greatest thing that they would die from in the next year would be violence. And we currently had no plan of preventative care for interfacing with the community. And at that point, the SafERteens intervention that we developed was a screening, universal screening intervention. We took everyone who came into the ED within this age group, whether they were there for an ankle sprain or belly pain, or whether they were there for a fist fight or a more severe injury, as long as they were stable. We screened them, and if they had any experience with violence in the past year, even minor violence, and any alcohol use at all, they were put into the SafERteens intervention, which was a about 30 minutes motivationally interviewing based intervention in the ED. At the time, single session, and then we followed them for 3, 6, and 12 months. We initially developed both a computer version, a tailored computer version, and then a version which was prompted on the screen for the counselor, but was not shown to the youth to walk them through the intervention. And we found that this intervention showed significant promise. If you want to go to the next slide. We found that in the therapist group compared to the control group, that we had significant intervention effects, even up to 12 months and even for a single session. We did not find that the computer, which was an early version of tailored computer programming at that time, for peer aggression specifically, we did not find benefits. We went on after this to replicate this finding in a number of settings. We replicated it both without the screening of alcohol and aggression, but just in a universal population in the ED. We've gone on to replicate it in primary care settings as well. Next slide, please. When we talk about violence prevention, we're talking about both peer violence as well as teen dating and partner violence. And we found that the SafERteens single session intervention actually also impacted and decreased both moderate and severe dating violence for youth that had some exposure in the past to dating violence in their relationships. Next slide, please. We went on to do a cost analysis of this, and not surprisingly likely for this group, prevention is very cost effective. And we found in multi-way sensitivity analysis that the cost per event for event of violence prevented, is somewhere between $4 and $50. $50 intervention is trivial. It's less than a bag of saline. It costs less than a tetanus shot. And so, this sort of approach, which the things about it that were really novel at that time and are still relatively novel, is this is why the youth are there. This is using the hospital setting as a place of intervention for youth in the community that have risk. And this comes up over and over again in that many of my colleagues, when we're working on how to do violence prevention in the community, will say it's difficult to be able to get access regularly to the youth and how to get them engaged. And from my vantage point, the kids just come. We open the doors up and they come every day. And we found that they were both eager and engaged in the intervention, and really just thrilled to have somebody asking them and talking to them about the violence in their life, which is often around them in many instances and is a chronic background exposure for them, as well as has current and ongoing issues in their upcoming future. And few adults in their life are actually talking to them about this in a straightforward, non-judgmental manner. And we got just a great reception from it over and over again. Next slide, please. So the kind of punchline from our SafERteens intervention that we learned from violence interventions to help other healthcare settings is even a brief intervention during an acute care visit really can decrease violent events. And that the ED really needs to be considered a place for prevention beyond the acute care. Now, I can never say this without my clinician colleagues quickly pouncing on me and pointing out that they have no capacity to do this. And that's where we have to think about as a setting for care, not necessarily that the care has to be provided by the existing healthcare staff who are already beyond stretched. We also found that even in the therapist version of the intervention, that computers were used to help standardize the counseling session. The acute care setting is hectic. Our therapists were often, delivering an intervention on the other side of a curtain to, a family or a child who was uncomfortable in some way. There's a lot going on in acute care settings, and having a standardized approach using a computer to help guide the session for the counselor developed a more an intervention that had more fidelity. And we think is one of the key reasons that is successful. It allowed for less deviation and allowed prompting by therapists with less clinical skill to be done. Next slide, please. We created, through the kindness of the CDC's funding and implementation package and toolkit for our SafERteens program, which is available here on our University of Michigan Injury Prevention website. Has all the materials and a toolkit and resources for hospitals to be doing this. We also have a partner companion primary care toolkit that has also been developed, and both have been demonstrated to be efficacious. Next slide, please. One of the other things, as I lead into my conversation on firearm violence, that we examined our team in the emergency department is looking at the youth that come through the ED that have some kind of violent injury, whether that's a mild injury, a first fist fight, to something that's more severe, a stabbing or a shooting. Really, until this study, which was done in Flint, it's called the Flint Youth Injury Study, we didn't have any concrete understanding of the life course or the course of injury or substance use in that time following the emergency department visit. So this study looked at time zero. Here is the time they came into the emergency department. The black line is it's a cohort observational study funded by NIDA, thank you very much, that looked at youth who came in, the black line is youth that came in with a violent injury or an assault injury, again, could be very minor, and then a matched cohort that came in during the same time course. And we followed them over the subsequent 2 years. And these kids are all living in Flint. They were 14 to 24 years old, all living in Flint, Michigan, and looked at what their outcomes were for a variety of things, including their substance use outcomes, which I don't present here. But we found those kids, even with a minor assault, had a 2 times risk for repeat violent injury than their control cohort. And their 2-year mortality was 0.8%. And given that these are youth, 14 to 24, that is a lot of mortality. We also found a stunning 60% of the assault injured youth, even with the majority of which did not come in with a firearm related injury, went on over the time course that we were engaged with them. We followed them every 6 months for the subsequent 2 years. 8% sustained a fatal or non-fatal firearm injury. And over 77% of those with a firearm violence noticed it wasn't a single episode. There's a lot of violence going on in the kid's life, and it's an opportunity we have at that moment. We have them at time zero there to try to interject in that trajectory with them. Next slide, please. One of the things that we did from that study is we developed a safety score, which is a risk score to do an assessment, a screening assessment with youth that come in through the ED to try to assess which youth would go on to be more engaged with firearm injury. This is the only assessment we know of from healthcare settings that has been validated. Asking these 4 questions. Next slide, please. We went on to predict a risk gradient in both the training and validation set that predicted future firearm violence. Actually, one of the recent CDC firearm funding that was just released this summer went to one of the colleagues on this, Jason Goldstick, who is now replicating this safety risk training score across a multi-site group of emergency departments to understand whether this indeed can be predictive in other settings, helping us to then guide our resources, which are scant, to who could use intervention most well seen in the emergency department. Next slide, please. Finally, other kind of outcomes or next steps from this work has been one of my mentees, Pat Carter, a NIDA K award here, which is taking some of the work that we did in SafERteens and then applying it specifically to firearm behaviors and violence, and then moving the technology forward from the computer-tailored version we had to firearm behaviors. Really exciting work, also using some GPS tracking technology to look at high-risk location to give feedback to the youth. I'm really excited to see how he moves forward with this. Next slide, please. I'm going to move through this quickly, but I just wanted to note here that some of the other work that we did, and we were working, and I was working at Flint long before the Flint water crisis. And this is CDC funding, where we looked at 2 neighborhoods in Flint, and we took many of the violence prevention techniques that I mentioned before, along with techniques and interventions that our partners are working, including community policing, clean and green initiatives, targeted outreach mentoring, and we applied them full court press to one neighborhood, the neighborhood in the blue on the bottom, compared to a control neighborhood. And we found that when we applied this suite of behavioral interventions across all the trying to touch as many youth as we could with as many of these techniques as we could in this intervention neighborhood, we were able to reduce violence. Next slide, please. Compared to the control neighborhood. And this shows the red line, if I get my colors right here, this shows that from the time we started the intervention, we were able to decrease both violent injury presentations measured objectively to the local hospital, as well as criminal justice offenses measured by the police within both of those neighborhoods. Next slide, please. So I'm going to move on now to talk a little bit more about firearm violence. And I know for anybody who's been watching the news in the last 24 hours, we have another national tragedy in Colorado. And this is an area where I was able finally to turn my focus to in about 2013, 2014, as it became both less taboo to be able to do so, and as increased funding opportunities opened up. And when I talk about firearm violence here, I'm talking about all kinds of firearm violence, from the mass shootings, this is up in the left in Las Vegas, to the school shootings, this is Sandy Hook in the top right, to unintentional injury with young children who find guns where they shouldn't be able to access them, youth suicide, and as well as peer violence. And with peer violence, I'm looking at both partner violence and intimate partner violence, as well as peer aggression with firearms. Next slide, please. So this is something our team is persistently working on and really focusing our attention now from the broad swath of violence prevention to really focusing on the most lethal type of violence, firearm violence, that we see in our country. And I always just remind people that when we come at this group may come at it with a more homogeneous perspective, but that there are a lot of perspectives out there, and we work with all of them and include all of these perspectives in the work that we're doing. Next slide, please. One of my favorite quotes by the former Surgeon General David Satcher on firearm injury as a public health issue. The country, I think, and federal funding agencies, as well as local researchers, are starting less to question why we think firearm violence is a health issue. But it's not that long ago that we all questioned it a lot and weren't really able to look at it more discreetly. And so I always put this slide up. Next slide, please. So when I talk about firearm injury, it's important to quantify, and I think it's good for a group like this to understand the amount of firearm injury and death that we have in the country. So this is among children and teens. So if you live through infancy in the US before your 18th birthday, these are your 3 leading causes of death in the country. The third, quite well funded, we'll talk about later, is cancer. The first remains motor vehicle crash, and the second leading cause of death for many decades now has been firearm injury. If you break that down into homicide, suicide, and unintentional or accidental injury, among a youth population, you can think of it about 60-40. It's about 60% homicide, which includes partner violence homicide, about 40% suicide, and then about 5%, 4 or 5%, roughly, is unintentional or accidental deaths. In an adult population, which I'll talk about in a moment, that number flips, and nationally it's about 60% suicide and about 40% homicide. Next slide, please. So after, boy, I think it was after Parkland, our team did an article with the New England Journal where we looked to quantify how firearm injury fit in a longitudinal standpoint as a cause of death for kids over the past decades. The blue line here, and the line starts in 1999 because that's when the best data set available really we were able to use began. I also like 1999 because it's about when I started working as a faculty emergency physician, and I was able to sort of feel these changes palpably in motor vehicle crash death from the early part of my career to a later part of my career. So motor vehicle crash death was killing about 10 per 100,000 youth in the 1990s. In the 1960s, there was a book put out, Unsafe at Any Speed, on car crash death. And in the time before the 90s, the amount of car crash death we had was actually even quite a bit higher. And we'll get to that in a moment. And it really decreased in the time in between. And that decrease, of course, is due to good science, but still levels off as the leading cause of death as of 2016. That changed actually in the later years, 2018, 2019. I'll show you that slide. Firearm injury, though, has remained the second leading cause of death that entire time, a fact that was really not well discussed or very well articulated over, I would say, most of the last 20 years. Malignant neoplasm or cancer has remained the third leading cause of death over this time among this youth population. Next slide, please. So this is a slide showing the amount of firearm injury, death by firearm injury, its mortality across urban, rural, and suburban areas. And I put this up specifically to sort of get at some of the mythology around or stereotyping public view that firearm violence happens in more one area or the other area of our country. So if you're a youth, again, over the age of lived through infancy before your 18th birthday, across those blue, orange, and green bars, you're about equally likely to die by a gun, about 4 per 100,000 in any of those areas. And that's a statistic that surprised me when we crunched the numbers a few years ago, and continues to surprise other people. So a youth is as likely to die by gun violence in a rural area as they are in an urban area. And again, here we're talking about mechanisms. So what's the difference? In urban areas, it tends to be more homicide, either peer or partner. And in the rural areas, it tends to be more suicide. As many of you know, suicide has been incredibly stigmatized. From a medical perspective, most of the folks who die by gun suicide die on scene. It has a 96% fatality rate. So those folks don't make it to a hospital, and so are not really considered by it's not a daily occurrence of people coming in on a stretcher the same way that first slide shows you is for peer and partner violence in urban areas. And so it's not felt, I think, as palpably by a lot of the healthcare community in the way that urban gun violence is. But the numbers are quite clear. Next slide, please. I just want to pause for the second for the national attention that school and mass shootings have gotten us, and we will have another round of news on this today, no doubt. School shootings remain less than 1% of the death of children and youth in the country, but have had a tremendous impact, obviously, on entire communities. And what's really even poorly understood now, and our team is starting to look at this and other people need to be looking at it, is although for every mass shooting we have, even the one in Colorado last night, the mental impact on the mental health community broadly is poorly understood, not well studied, and the cycles of violence that happen and emanate from it are still have a lot of research to be done. And then further with that, we have a lot of research to be done to understand how to mitigate and buffer resilience in our communities around this sort of trauma. So great focus of future work. Next slide, please. This is a scary trend line, which shows from 1999 through 2017. And I'm sorry, I didn't update for this this slide, but if I looked at 2018 and 2019, 19 is the last year we have data, the trend line continues to go up. It flattens a little bit in 2019. This is firearm mortality. So if it feels like more people are dying of gun violence, it is not, in fact, just the news or the news being sensational. More people are dying of gun violence every day. So, people are starting to get used to quantifying how many people are dying per day of COVID right now, for example, or by opioid deaths. We still have over 100 people dying every day by gun violence in the country. And as you can be knowledgeable in speaking about this with peers or colleagues in your communities, if we think about the, I believe the last number I heard from the news last night of the Colorado mass shooting was 10, 90 other people died of gun violence yesterday also. This is a tremendous problem across all of our communities. There's a lot of discussion that could be had on which kinds of gun violence gets presented to the national news media and which doesn't, which hits national news and which hits local news. But gun violence is a problem in all of our communities, and it is an increasing one. Next slide, please. When you look at that trend line, the next question people often will ask is, well, is that just homicide, or is that just suicide? Is that just one age group, or what's really accounting for that increase? And the answer here, which is a messy slide to look at, is the blue lines are the more recent years, and the gold lines are the older years. And really, it's up in every category. So it's not one. This is not just being driven by suicide. It's not just being driven by urban gun violence. This is across all really age groups, all mechanisms, except for very young children and unintentional injuries. Appear to have been stable, not decreased, but otherwise up in every age range, every mechanism. Next slide, please. My state of Michigan, I come to you from Ann Arbor today. A contrast that I think helps people understand that, again, we were surprised when we crunched the data to see is that guns killed more people than opioids did in the past decade in the state of Michigan. And the reason I like to bring that up is many of you here have spent an awful lot of time both on study sections, funding mechanisms, writing papers, working with colleagues, talking about the opioid crisis. But our inability to speak clearly and articulately in a science-based way due to the political pressures over the past decade have led to us not talking about what those numbers really are for gun violence. And so when you think about how many people opioids are killing in your community, you should know that likely as many or nearly as many people died in the past decade from gun violence in the same communities. Next slide, please. This is true, I threw about Florida. This is California, sorry, was as true in California when I last pulled the data from 2018 as it was in Michigan. So bigger states, smaller states. Next slide, please. When we talk about funding, I'm really excited on the increase and the opening up of funding at both the NIH and the CDC over the past few years. I'm eminently grateful for this. That has allowed some of my junior faculty to start to see that there are careers studying this and help us develop a pipeline of researchers that was sorely lost for the decades before. But just to really put it in perspective so people understand, we talked about gun injury, over a decade of 20,000 deaths, an average funding per year over that time of $1 million per year was all that we were having for federal funding. When you think about the decreases that I showed you in motor vehicle crash in an earlier slide, we got that decrease because, just the government alone funded $88 million towards understanding airbags and drunk driving, and not to mention what was put in by the car companies to think about safety. Cancer, we've had tremendous success in cancer deaths over the course of just my career. Many childhood cancers are now seen as on the verge of being completely curable diseases. That is because we believe in science, and science put forth $335 million every year towards finding the solutions. So when we think about firearm injury and we think about the kind of mass tragedy we had in the country yesterday, and we think that this is an impossible problem and one that doesn't have solutions, I really want to just remind people it's not that there aren't many solutions, it's that up until very recently, we have decided to not fund them. Or not fund their investigation. And we're moving away from that, thank goodness, but it's going to take real funding and an entire pipeline and generation of researchers to come along and be able to get to the answers for this. But then we can do it. It's not more complicated than car crash and cancer. Next slide, please. When we talk about that funding, our group did some looking in a health affairs paper a few years ago. We talk about new knowledge generation. That funding of, in this case, it was 12.5 million over a smaller amount of time, and to get to the $1 million per year. What does that mean? It means for publications over that entire time, there were only 540 publications in the literature, and most of them were not very high quality. We all know that to do rigorous science, you need real funding. And without rigorous and large funding, a lot of the publications that were put out were of modest scientific rigor, which doesn't help the field move forward, compared to the same funding in motor vehicle crash or cancer, which led to this tremendous amount of publications, which means new knowledge and knowledge that's getting out to the field for solutions. Next slide, please. So this is really a slide to remind us on how much we have to build the pipeline around firearm injury violence science. So in 1996, with the Dickey Amendment, when we had really the ending of serious federal funding, by 2010, we had total federal research on gun deaths was only at about $135,000 a year for the entire nation for that year, even though it was that second leading cause of death. The other problem with that is, and I came up in my early career during this time, 1996, I was looking for fellowship opportunities and wanted to study gun violence, and there obviously were none. And what that led was to this entire decade of a loss of a pipeline of postdocs and junior faculty and senior advisors that were working on this topic. And that's a loss of the knowledge that then could be transferred. And obviously myself and many other people looked at violence generally and looked at substance use broadly. And these things are obviously relevant to firearm injury prevention, but it's not exactly the same. And so we had a real loss of pipeline that we're going to have to work hard to rebuild now into rebuilding this field. And that first step is really having the funding available so that people can see, academics, we all know you need grants to move on for promotion. You need publications. And if one doesn't get grants because there isn't funding, then you tend to choose a different field to be in where you can move along your academic career. The other problem it led to is by 2017, we had so few firearm injured people looking at the data sets around that data that I showed you last, gun deaths in 2017 surpassed car deaths for teenagers. And should have been a big headline, but it wasn't a big headline because there was really nobody around counting firearm deaths at the time. The teams weren't looking at that. So next slide, please. I mentioned this, the kind of analogy to transportation safety, I think, is really important. And the formation of NHTSA, which was part of the outcry of the carnage on the roads in the 1960s, was a really important step, but just increased focus on this as a problem. That resulted, we have from the 1960s to now, because of NHTSA and the funding and the way that we think about all injury prevention broadly around motor vehicle crash right now, from the car to the road to the driver to the behavior to the drinking, 76% decline in motor vehicle crash deaths. I believe that we can get to 76% decline in firearm injury prevention deaths over the next 4 decades if we invest in it and take the science seriously. Next slide, please. This is a slide that basically shows you that same thing. It's, science got us there from 1965 in that first really cry for cars being unsafe at any speed. We developed seatbelts, we developed NHTSA, we developed the first car seat law, drinking age change. This was all science. And then the policy got examined as science. This is all research in action, not an accident. Next slide, please. Next slide, I'm going to skip this and move ahead. One of the things that I think is really important as we talk about firearm injury prevention is think about reframing this. I don't like the word gun control. It's not something that I support. I'm very much supporting gun safety and gun safety research. I think some of the framing was handed to us and we think about the wrong way. When in the 1960s, there was never an option on the table that we were going to take away cars. And that was going to be the solution to safer transportation. We thought about how we were going to study this, create better science, create better behavioral interventions, implement them, create better roads. The same thing with the idea that that we put forth that the absence of this will make it better. We don't talk about that for other types of injury prevention pools. We think about how to mitigate risk. We think about how to get people to understand the risk of having a pool if they have young children. These are things we can accomplish together, but we need to think about this scientifically and get away from some of the bad rhetoric that's been out there. Next slide, please. We thank and are very grateful to NICHD for funding our group for the FACTS Consortium, the Firearm Safety Among Children and Teens Consortium, which started 3 years ago now. We're now in year 4. And we've brought together really the leading scientists on this in the country across 12 or 14, I think, institutions that we're up to now to rebuild the pipeline of trainees on firearm injury prevention. We funded a number of small pilot projects. We reviewed all the existing literature out there and did gap analysis on it and have this all on our website for what the what we think the most pressing science questions are that need to be answered in the field, and continue to move ahead and have had also annual conferences, really shifting the narrative to this is something that really was not going to be well studied among serious scientists to this is now a legitimate field of study with serious scientists working on it with rigorous methodology. Next slide, please. This is just an overview, I'm sorry, a poor quality slide here of some of the many partners that we have working on this together. Next slide, please. We've taken a standard approach looking at surveillance and epidemiology, risk and predictive, long-term mental health issues, policy analysis, looking at the recent IRPA laws, the extreme risk protection laws that have come out. We have a data repository now at the University of Michigan through FACTS that is consolidating. We have over 100 data sets that have firearm variables in them that are great for your mentees or junior faculty that are interested in secondary data analysis. Next slide, please. It was really important to involve a stakeholder group across the political spectrum that have been essential to guiding us across this journey in firearm injury science. Next slide, please. I put this up. This is the Academy of Surgeons a few years ago, maybe 3 years ago now, gathered most of the medical specialties representatives together and got on board in signing a statement, which should not seem shocking, but is to agree that violence was indeed a public health problem. One specialty that shall not remain named still wouldn't sign on, but this is really a tremendous success and a big shift in the field that is still just very fresh, just 3 years ago from where we were before, where in most of these societies, including my own specialties groups, where we weren't allowed to talk about firearms in our injury prevention groups at all. Next slide, please. We have an annual symposium now. It happened virtually this past year during COVID, and this September, actually, October 4th, we'll have another annual presentation. It's the only national science-based firearm injury research prevention conference, and we welcome and encourage your participation. Next slide, please. People are frustrated by firearm violence, especially in a time, the last couple of days and this most recent mass shooting. And I just want to give some encouragement, especially to a group of behavioral health folks who understand this, but culture change takes time. And we've made a tremendous difference in the past decade in moving forward our thinking on firearm injury prevention. And there's a lot of momentum now behind the science. I like the middle slide here because this was my mother's generation who were encouraged to smoke. They would have smaller babies that would be easier to deliver, is what she was told. And I think, my daughter's generation will think that we were probably equally ridiculous in our initial approach to firearm violence, and hopefully we will have made some gains by then. Next slides, please. I would be remiss if I didn't mention, as I come to you also today, in addition to a researcher, as the Vice President of Research here at the University of Michigan, that it's important that major academic institutions take this on seriously. And I am incredibly enthusiastic and proud that our university president and Michigan has taken this on as a leading presidential initiative. And we are working to fund now and to kick off a large focus of science on this on our campus. I encourage other institutions and organizations to also take this on. We will all need to be working on it together to make substantial change. Next slide, please. So I will finish by just giving you some places to follow. Our FACTS initiative is at childfirearmsafety.org. I often talk about such things on Twitter, and our new University of Michigan presidential initiative on this is at firearminjury@umich.edu. And I would be happy to take some questions now. Thank you so much for your time and attention.
Great. Thank you so much. This is Dara Blackman-Demner. I'm here from OBSSR, and Dr. Cunningham, you are like exactly on time at 2:45. So we have 15 minutes for questions, which is wonderful. I think that was a fabulous talk. And I will just remind folks, if you do have a question, please type it, choose all panelists and put it into the Q&A, and we will get through as many of them as we can. So the first question that came in, I think this is talking about the SafERteens intervention, the screening. It says, do you think that this intervention would be effective as well in adult populations, or is there something unique in the youth population that makes it particularly impactful?
So I think it's important to have a developmental perspective. And so what we couldn't, we've worked with adults through age 24 with it. And actually the mean age of some of the more recent work we've done with it has been more like 19 and 20. So certainly, adult populations, young adult populations. The way it could be adapted to an adult population, likely, although in a developmental time course of violence, adults that are still engaging in violence in their late 20s and 30s may have a different developmental course altogether, and may be engaged in, have other risk factors and other patterns of violence and serious engagement in violence that is different than the population that we were dealing with in the 18 or 16 to 24-year-old age frame. So in that age group, even if they had been engaged in significant prior violence, they're at a developmental trajectory still that may be more open to this sort of less intensive intervention. So SafERteens is a single session intervention. We've done follow-on work to that where we've done 3 or 4 post sessions after the emergency department, and we've found good effects with those as well, particularly for some of the, so that's been helpful as well. But to adapt it to an adult population, you would have to address the developmental differences in that stage of life. But it certainly, there's also been way more funding for youth violence than there has been for adult violence, separate from IPV. But there's no reason to think that there can't be effective violence prevention programs for that would be similar motivational interviewing based for a middle age violence population.
Okay, great, thank you.
Yeah.
Yeah, so we had one question that came in that was about the efficacy of a particular policy, but I'm going to sort of take the liberty to kind of expand that a little bit. So you mentioned some of your work where you've started to doing research on the ERPA laws, and this particular question was around gun buyback programs. And so I'm wondering if you could just speak a little bit to sort of the broader question of your experiences in doing research on the effectiveness of these various policies, and some of the potential challenges to that work, and maybe any thoughts for
I'd be
how
happy
to move forward.
So a couple of things there. One, good efficacy data on almost any of our policies around gun violence is sorely lacking, is the first thing I'll say. So partly because, as I mentioned before, there really are a handful of folks in the country that are examining the effects of policy, of gun violence policy. We need to train that pipeline desperately. So that's the first thing. So the ERPO laws, extreme risk protection order laws, for those folks that don't know them, these are laws that were put into place in a variety of ways around the country most came out after Parkland, and they allow for if you think that someone is at risk for, say, going and committing a mass shooting accident or for domestic violence and they have a gun, you can, in some states, go and petition through an extreme risk protection order to have that gun held temporarily from that person until that time period can pass. More work is needed, but there's been a number of studies that are high quality that have looked at this in both Oregon and Washington that have shown or that have preliminarily shown that they have indeed prevented a number of violent instances and show a lot of promise. Where we need more work there is the policies are rolled out differentially across those states, have different requirements around them. So we need to do more deep digging to truly understand all of the nuances of them. But that is an area that shows great policy promise. And then we have to think about how that's implemented across the different states. One of the other areas that's an issue in examining this is I just can't speak loudly enough to the lack of our data on this. I mean, for example, we have no data. The data that I'm giving you on gun violence is still now 2019 data is the national data that's available. In many states, there is not any regular tracking of just mortality. Forget injury. There's no reliable national tracking right now of the number of gun injuries. There are a couple of nonprofit organizations that have taken it upon themselves to try to create that database, but from it's hard to understand efficacy of things if we don't understand how many people have either died or been shot just in the most crass, gross manner. So that's data that's difficult to get, and it's something that if we want to understand how laws and policies, when they're put in place, how efficacious they are, creating a standard reporting expansion of, for example, the NVRDS to really good reporting of not only firearm deaths, but firearm non-fatal injuries is of critical importance. There's a variety of other programs out there on, from all kinds of community programs. I guess I'll just leave it at that. That show there's a varying degree of efficacy for the URPL laws have the ones that have shown the greatest promise recently. Some of the other child access prevention laws, and we did a review actually of the existing policy, the existing laws out there for children, published in the Journal of Behavioral Health last year. And the two policies that showed the greatest promise in a systematic review were child access prevention laws, where people have an active disincentive to make sure that young children don't have access to firearms that they can't competently manage, and then the URPA laws.
Great, thank you so much.
Yeah.
Now, looks like, let's see, I think we have time for a couple more questions. So another question that is specific that I'm going to maybe broaden out. So the question is notes and particularly relevant now, I think, since last year, Asian American gun purchase has increased in response to anti-Asian sentiment. Do you have any thoughts about this interface with healthcare and culture or culturally responsive appropriate violence prevention? And I'd obviously love to hear your thoughts on that. And I guess I would just expand that. You presented some data by race and ethnicity, and you talked a little bit about sort of the kinds of firearm events that make it into the media versus those that don't. So any sort of general thoughts about how this interfaces with these larger conversations we're having around structural racism and health equity?
I'd be happy to. I mean, I think from a research perspective and as a data geek, the first way that we're going to find any of these solutions is by, as I mentioned a moment ago, so I'll be a broken record, is by more clear data. So we don't have great data on health equity across any number of health issues, right? This is just becoming really more visible to many people in the country. So understanding differential rates of impact across our communities, across any number of health issues is really important. Firearm injury is certainly no different. We don't have great data on, as I mentioned, firearm non-fatal injury across any group on any given day. As we develop those data systems, understanding gender and race and local community context within those is also really important. And as we understand that better, then we can help develop culturally specific and tailored responses to that in partnership with the communities that are impacted in the ways that can be most responsive. So, gun ownership is up, gun purchasing is up, certainly. There's also not our FACTS group, our Firearm Consortium just did a national survey, which we'll be publishing over this next year on adults and kids in reasons that they own firearms and how they're stored and things like that in their house. We wound up doing it in the middle of COVID, which of course was not the way we planned it, but it also gave, and in the middle of all of the unrest of last summer, which gave us also a window into perspectives on race and the pandemic around gun ownership as well. So look for that information as it comes out. But we need a lot more systematic data to come out, and then we need to be persistently paying attention to the health equity issues. I did not mention in here specifically, but as firearm injury and death has been the second leading cause of death for all children for decades, it is now the leading cause of death for teenagers, regardless of race. Firearm injury and death has been the #1 cause of death for African American children who lived through infancy for decades also. So there are certainly race overlay, and we need to understand these better and have culturally responsive, appropriate interventions in partnership with our communities.
Great, thank you. I'll definitely be looking for that that survey paper. So I'm going to give our director the last word. And so a question from Dr. Riley, which I think would be great to hear your perspective on. So as you know, Congress has provided $12.5 million to NIH over the last 2 years for firearm violence prevention work. And given that it's still a relatively small amount, we have largely focused on funding new research. As you spoke about, there's clearly a need for building research capacity for the future. And so should we in the future receive a larger and or more extensive funding for firearms, do you have any thoughts about how to appropriately balance building that research capacity with the urgency of getting new research out the door?
By new research out the door.
Well,
so we have capacity building. Go ahead.
No, go ahead. I was just going to clarify. I think, and Bill, feel free to jump in since this is your question. I think the question is, we haven't, in the last 2 years, we haven't really focused on more training grants or kind of typical capacity building grants. We've been focused on, our 21s, our 61s, the sort of innovative pilot kind of things. And so, I think just a sense of your sense of where how to appropriately balance.
Yeah, I have thought a lot about that. So really FACT's entire mission has been around capacity building. So we have to build a whole field. And my approach to that has been, there's a lot of people who are working in a very related field that will pivot. We all know our researchers, 10 years ago, we didn't have researchers working on opioids either, right? Everybody was working on cocaine or something else. Our research community can pivot when given the, incentive, the, lack of political downside, and the funding to do so, and they pivot miraculously. So there's all these fields that are tangential. When I talk to people, they don't view themselves as firearm researchers, but they easily could be. They're doing community violence work, they're doing other substance use related work, they're doing work in rural communities, all of which have these incredibly high rates of firearm violence. And so we before we can have a lot, it's important to bring trainees along, but we need mentors. And so and we don't have enough mentors in this field right now, but we have a lot of people in related fields that if they pivot and start working some on adding these variables and these questions that are specific to firearm violence to all the work they already do, we will both broaden the field as well as then provide opportunities for them to bring trainees along the way. And I think that's the way, that's my approach to the University of Michigan is first to get all of our scientists around campus to take the work that they're doing and start to think about how it is related to firearm violence and how they can get inclusive criteria and inclusive variables in that don't often even add very much. Another way to build capacity would be how you could take grantees that you already have and get them to add on variables and components to it that are related to this, who are working in a field that is associated, but they haven't called themselves or been focused head on firearm violence yet. The same thing with suicide researchers, often do not think of themselves as firearm researchers. However, the leading mechanism of cause of death for suicide. So I'm trying to get all of the suicide folks that we work with to start to make sure they're including firearm variables in their work and thinking about it from a mechanistic standpoint, and not simply on the back end, which we were sort of all trained to do over the past decades, was to ignore this elephant in the room of the mechanism of the gun and sort of talk around it, and instead to now just address that in an objective, science-based way head on.
That's great. So Dara, thank you. But Rebecca, thanks for that perspective. That's really helpful as we try to, it would certainly be a good problem to have where we have enough funding for firearm violence research that we have to think about how to develop research capacity and fund, new research concepts and ideas, and also pull from related areas as well. So that's really helpful. So Rebecca, once again, thank you for taking the time to do this today. Just a reminder for folks as we wrap up, the presentation will be available in a couple of weeks on our site in terms of a video, so you can look for that. Our next OBSSR Directors webinar will be Tuesday, July the 20th. It'll be Dr. Elizabeth Howe, who's the chair of Department of Obstetrics and Gynecology at Penn Medicine, presenting on racial disparities in maternal morbidity and mortality. So this concludes our webinar for today. I want to thank you all for attending. Thanks to Rebecca Cunningham again for presenting, and all of you have a great day. Thanks.
Thanks so much. Bye now.
Thanks, Rebecca.